Since radiofrequency was approved 25 years ago now, we have had lots of different options. Obviously, prior to that, we had the stripping and other surgical options, but we have laser, we have non-thermal ablations, including MoCA, including cyanoacrylate blue, and polydocanol, which is available in the United States. And then you have the physician compounded foam anyway to take care of these patients. So there's a vast list that is now available to take care of these patients. And all these are tools in the toolbox to kind of take care of our patients' pathology depending on their anatomy and presentation. There's no head-to-head sort of comparison to assess which has the least complications. Everything tested head-to-head has been success of the device and the success of the treatment. And all of these are the same, very similar, especially the thermal and the cyanoacrylates. Maybe a little less anatomic success with the microfoam. But what I'm looking forward to is the VenaSeal Spectrum trial. I can't think of another larger trial or more important trial in this space because A, it is the largest post-market study in the space of superficial venous interventions, and B, it is going to assess the role of closure of great saphenous vein in the treatment of venous ulcers. First off, at the patient level, not all vascular medicine folks practice interventions, and not all vascular surgeons practice venous medicine, and the same goes for interventional radiology or cardiology. So, when I recommend a younger person to take care of venous disease, I tell them to jump in, with both feet into the field and not make it like, a side, operation of whatever their major operation is. Because these patients, need a holistic care, right? And it is, if you're unable to, offer the full spectrum of venous treatments, you got to collaborate. For example, there are, large venous aneurysms that I send routinely to my vascular surgery colleagues who are my partners in my practice. And on the other hand, the vascular surgeons would send their complicated thrombotic patients with reflux to me because I deal with, hypercoagulable states and venous interventions. So it's a very nice blend there of taking care of the patients by the right person. So it really works great to have that team, and for us at OhioHealth, that has been a wonderful thing to have great vascular surgery partners. The unmet needs are still to understand, which procedure to do first in post-thrombotics. If you have deep venous reflux, superficial venous reflux, deep venous disease, superficial venous disease, what is the order to go? That is one. And, venous ulcers, do we treat the reflux first or the obstruction first? You have data from Everett trial, which tell us that, for a small wound, you don't probably need to treat the deep system. But for the larger wounds, we all believe that, we need to treat the deeper system first the deep system first before treating the superficial system. There's no science to support that. That's very important. We also, don't have any data comparing thermal ablations for saphenous reflux to, let's just say, physician compounded foam, which was used in 50% of patients in the Everett trial. First priority is to assess whether the deep is responsible for the ulcers or the superficial is, and also the second thing that need to be understood is what is a true hemodynamically significant lesion if there is a deep venous lesion. So that's one. And then the test in a research trial to look at the success rates of physician compounded foam in the treatment of axial reflux in comparison to the thermal and other non-thermal. And finally, subulcer plexus treatment. in venous ulcers, all of us who take care of these ulcers, we actually use sub-ulcer sclerotherapy, ultrasound guided. A vast majority of us do, but there is no data to support it. So I'm looking forward to that trial to be done as well.